and we'll jump in.
We're all ready when you are, Dr. Gregory.
Okay, well, we'll go ahead and jump in because there's a lot to cover. So today's topic is basically covering movement, nervous system diseases, motor and muscle diseases. So there's a lot to go through. Clearly, this isn't going to be covering on every single topic they can possibly test you on, but I'm going to try to really focus in on the high yield topics that you're more likely to get tested on with the boards and more likely to encounter in your clinics. So with movement disorders, basically they can localize to anywhere on the brain, central nervous system, peripheral nervous system, neuromuscular junction, or muscle pathway. So it's a lot to cover. I'm going to assume you guys are fairly familiar with the anatomy already, and we're going to jump into hypotonia in infants, which is a very high yield topic they love to test on. Cerebral palsy, which we see a lot of, and regardless of what you go into, you're going to be running into these kids. And then muscular dystrophy, which is also highly testable. And there are some fairly new treatments that are out that have been out for long enough for you guys to be tested on, and more than likely are going to start showing up on test. So additional reading, I love Peds in Review. They tend to get to the heart of the matter pretty fast. I'd recommend looking at muscle disease, ataxia, hypotonia, cerebral palsy, and movement disorders. Also take a look at the article on developmental delays in general and the testing to look at. If you're having any trouble accessing these, let me know. Those of you who have rotated through with us before have already gotten copies of most of these, I think. There are certainly things that are possible that simply aren't going to be covered in those or in the lecture today, specifically peripheral nerve injuries. Guillain-Barré tends to be tested. Certainly it affects peripheral nerves, but as far as degenerative peripheral nerve diseases, they aren't really highly tested. However, they can occur in children, more common in adults, but they can certainly happen. One thing that you should be aware of is brachial plexus injuries, particularly relating to birth. They love to test on that. So we're going to jump into hypotonia now, specifically thinking about the floppy infant. So hypotonia, when we're talking about tone, we're talking about resting muscle tone. And it can be related to strength, but oftentimes tone can be affected in isolation. So the children have the ability to move well against gravity and resistance, but when they're not moving, their resting tone can be quite low. And this is apparent simply upon watching them. But if you passively move the joints, you're going to feel this abnormality, this low tone. And so this low tone is going to affect their postural control. It's going to affect the movement around the joints. You're going to have an increased range of motion. You're going to have less coordinated movement because you have that laxity, and there's going to be an increased requirement for strength and agility to perform the same movement. Weak infants are always going to have hypotonia, but you can have hypotonia without having weakness. And anytime you're dealing with a hypotonic infant, it's important to kind of assess, is this isolated hypotonia, or is this hypotonia with weakness, because these are going to be caused by different things. So when you're evaluating the infant, always it's going to be important to know the birth history, the patient's past medical history. Were there concerns before the baby was born? Were there complications during delivery? Did the child require resuscitative measures? All of these are going to be clues as to how long this has been going on and what could potentially have caused it. Also, whenever you're assessing the child, is this something that came on acutely? You know, is this a perfectly healthy kid and at 3 months old, suddenly they're very low tone? Or is this something that's been apparent since birth? Is it gradually progressive, or was it immediate in onset? Does it have a fluctuating course? If it's progressive, is it rapidly progressive or slowly progressive? All of these are going to be important things to take into consideration. Often a hypotonic infant was hypotonic in utero, so you may have findings with delivery that indicate that, you know, breech presentation or other things of that nature. When you're looking at the child, just watching the child at first is going to be really important. You'll be able to see, you know, are they moving on their own? But when they're resting, how are they holding their arms and their legs? Babies, a healthy full-term infant is going to be pretty tight feeling. I know you guys are all aware of that, but they're not going to have their arms and legs just lying limply beside them. And so watch them, how they're just lying there, and then move them around a little bit and see, as you're holding them, you know, are they resisting gravity, or are they just kind of flopping wherever they are not supported strongly. And then with older kids, looking at scarf sign, which is whenever you kind of stretch your arms across the body in front and in back. If a child is hypotonic, even if they're older, it's going to be like moving the limbs on a cooked chicken. You know, you're just not going to be getting that resistance. And also looking for signs of traction. So this is a good picture of a floppy baby. You can see they're just not holding their back straight. They should be, their back should be straight. Their arms should be in flexion. Their legs should be in flexion. The head should be held more supported against gravity. And instead, this kid is just kind of leaning into the gravity, which is not what you want to see unless they're heavily sedated. And so this is a 2-year-old girl, and you can see picking her up underneath her arm. She's just kind of slipping through. And you would expect there to be resistance, the arms to kind of stay down. You would expect her head to be a bit more forward. If you looked at her over time, you know, you would expect her to be able to lift her legs up and not hold them quite exactly in the sort of frog leg position, which from this angle you can't really see. But this is definitely abnormal. Then we've got a boy who has like massive degree of head lag. And of course you want to make sure he's not just arching his head back, but a child that's 15 months old should have many, many months ago gotten full control of the head. And so it should not be looping back like that. Even in a newborn, you would expect a little more head control than that. So that's going to be highly concerning. You're going to look for other things as well. We'll have some pictures in just a few slides of W sitting and frog leg posture, but these are things that a child with normal tone isn't going to do just of their own volition. Oftentimes as kids are developing and they're getting a bit older, they'll commando crawl rather than have the full sort of upright crawling position. And again, this is due to the hypotonus, the laxity around the hips and the shoulders, and it requiring, you know, they've got full strength, but it's not enough to overcome the laxity around the joints. And so even though they're able to move, they're commando crawling rather than a full mature crawl. They may have wide-based gait. They may have a substantial lordotic posture because of the decreased tone axially as well as appendicularly. You may see difficulties with feeding due to tone. You may see this sort of laxity in the face due to low tone. They may have joint laxity. You may over time see that they're continuing to have primitive reflexes that are not going away like they should be. Or if there's significant weakness, they may not have the reflexes like they should. So if you're doing a moro, you may not see the movements that you're expecting due to that low tone. You can sometimes see clonus as well. And in newborn babies, a few beats of clonus is nothing to get alarmed over. Asymmetry is something to be alarmed over, and extreme clonus is going to make you think, hey, maybe this child had an injury in utero, maybe they're developing into a CP type picture, because initially, you know, they're going to be low tone with that before they develop hypertonic findings. So this is our classic frog leg posture. And you can see the legs out like a frog leg, but also the arms, you know, they're lying limply over to the side. And with this child, if it's solely hypotonia, when you agitate them, they're going to be able to move their legs and arms against gravity and against resistance. So when they're active and angry, things aren't going to look abnormal. It's when they're resting that they're just going to look limp and kind of lifeless, and really kind of show you that resting tone. Tone is incredibly hard to assess in a very agitated infant, or even with older children. You know, you have to get them relaxed a little bit to see what that resting tone is. And so this is W sitting. OTs and PTs hate this. It's bad for your joints long term. But a child that has normal tone isn't going to do this. To rest in that position is in and of itself indicative of hypotonia. So one of the things the therapists do is try to get kids to avoid these postures that they're going to because of the low tone, because it can cause long-term injury and increased stress on those joints due to the abnormal posturing. Hypotonia, where does it localize to? Can be pretty much anywhere. The primary cause, or the most common causes rather, generally are central, and it's either going to be a type of picture where you've got a specific lesion or a history of an injury, or you may fall into this benign hypotonia category, where it's not necessarily fully benign, but there's no primary cause that's been identified. And then anywhere from 15 to 30%, probably closer to 15% of hypotonia is due to more peripheral causes. And these are going to be cases where you're not finding a whole lot else on exam other than these motoric findings. And many times this can be indicative of something not necessarily more concerning than a central cause, but something that you would need to treat separately and differently from what the child is being treated for anyway. When you have central hypotonia, sometimes you may have cognitive impairment. You've probably noticed in a developmental clinic that unless a child has cerebral palsy, the vast majority of these kids are very hypotonic. They kind of go hand in hand. That being said, a hypotonic kid doesn't necessarily have cognitive delays. However, if the child has cognitive delays, you're going to be more comfortable in saying that this is most likely a central cause. Central causes are also more likely to be found whenever the child has either normal or brisk tendon reflexes. If you're seeing hyperreflexia or areflexia, it's more likely to be peripheral or to be an acute central injury, because right after, say, a stroke, you're going to have hyperreflexia. Over time, it's going to become hyperreflexic, and over time as well, you can switch from a hypotonic picture to more of a hypertonia, but the reflexes may become more exaggerated earlier. So with a central hypotonia, you're more likely to see normal strength. With peripheral hypotonia, you may have muscle weakness, you may have muscle atrophy. If you're dealing with like a motor neuron issue, you may see fasciculations, like that really jumps out with spinal muscular atrophy. When you're dealing with central hypotonia, you're also, because you're dealing with a disorder of the brain or the spine, going to be more likely to have seizures, which in and of itself you would not expect an increased rate of with peripheral hypotonia. With peripheral hypotonia, though, you may see more systemic issues. So you may be more likely to have respiratory impairment. You may be more likely to have feeding impairment. And these are often kids that the weakness may be very obvious just from glancing at them. So what causes central hypotonia? Hypoxic ischemic injury is one of the major causes that we see. Many times over time, these kids are going to progress into a hypertonic picture. However, that's going to take weeks to months to get there. So initially, when the children are born in the NICU, they're going to be really limp at rest. Any other encephalopathic causes, bleeds, unless they're something that has happened historically, can present themselves with a hypotonic picture. You may have some more focal findings with that rather than a full potty. Any chromosomal disorders are often associated with hypotonia. Some can be more hypertonic, but all of the trisomies tend to be, hypotonia is very apparent on exam. Prader-Willi is well known for having a really marked hypotonia just from birth. And there are a variety of other syndromes as well that, the hypotonia is very profound. Inborn errors of metabolism can be associated with hypotonia as well. I'd say the majority of them are. There are some that affect the basal ganglia first, and therefore there can be more of a hypertonic picture. But if you're having a really limp child, you don't have a good explanation for what's going on, definitely look at those newborn screens, look at the results of them. And if you don't have a good explanation and there's no history of like HIE or anything along those lines, these are kids that I do like a basic metabolic workup where you're looking at, serum amino acids, urine organic acids, all of that kind of stuff. So peripheral hypotonia. In these conditions, it's either the peripheral nerves, the neuromuscular junction, or the muscles themselves that are causing the hypotonia. So this can be myopathies, myelopathies, myasthenia, anything along this neuromuscular axis outside of the central nervous system. One of the things that classically on tests at least causes hypotonia is going to be botulism or other accidental poisonings where you've got this neuromuscular junction blockade. You can also have mixed hypotonia. Nothing's ever super simple in real life. So with these, you're often going to be looking at metabolic causes as well. It may be mitochondrial causes. Sometimes with hypoxic ischemic injury, you can also have peripheral injury. Be aware that you can have a mixed picture. So always be concerned about sepsis when you have a newborn that's hypotonic. But if that is clear, then your next step is going to be neuroimaging, evaluation of the history to see if there's any evidence of HIE or a bleed. If those are abnormal, then you're going to be looking more towards metabolics. Always with a newborn, torch screen, evaluations for metabolic derangement, urine drug screen. Drugs can certainly cause it. If mom was treated with excessive magnesium during the delivery period, the baby can also have hypermagnesia, which is going to also make them super limp. That, of course, is going to go away on its own. You just have to support the kid during that time. So evaluations. For central causes, you're probably, unless you have a very good explanation off the bat, you're going to want to get genetics involved, and they'll help decide exactly what to send. You're going to want to look at the newborn screen if you've got the results back yet. You're going to want to send your basic metabolic panel. And we've got listed the majority of the things that you would send with that, unless there's something else that's kind of jumping out as far as history or other abnormalities on exam. Imaging is going to be critical to helping you, especially if you don't have a straightforward history of, a problematic perinatal history. With peripheral causes, one of the primary things you're going to jump to is creatine phosphokinase, CK. That's going to be very helpful. We'll get into that a little bit later when we're talking about muscular dystrophies, but that can really help you zero in, and particularly if you're trying to decide, are we dealing with central versus peripheral, that can be of use. EMG nerve conduction studies can also be helpful. They can assess for pathology in the muscle. They can assess for peripheral neuropathy. The downside with that, of course, is that we have a lot of difficulties getting that inpatient. So there's really no one at the hospital that's going to do that on anyone under 18 years of age, certainly not in the NICU. And so we don't have that particular tool at our disposal in the acute inpatient setting. We rarely these days use muscle or nerve biopsy. That being said, on the test, that's probably a valid choice. But it's painful, and for the most part, genetic testing has supplanted that as a way of confirming a diagnosis. And then specific genetic tests, many times with peripheral causes, you're going to be zeroing in on a likely diagnosis or likely family of diagnoses. Many times they may go ahead and send your general SNP array anyway, a chromosomal microarray, or get your basic chromosomes anyway. But many times you look at a child and you think, this is probably SMA, in which case you're going to test for an SMN gene, as opposed to a more scattershot approach. And then if that's negative, you're going to have to go deeper. But many times the peripheral diseases, you've at least narrowed it down to a family. Most of this, I think we've already covered. This is just describing in further detail some of the things you might be looking for. So central hypotonia, secondary to injury, generally ultimately resolves into hypertonia and hyperreflexia over time. So keep that in mind whenever you're doing the workup. But certainly, if a baby is born hypotonic, we don't know necessarily the timing of the injury. And so this is something that's likely to change when you see the child in follow-up, but may not change throughout the NICU stay. When you're dealing with syndromic disorders, so things like trisomies, you're more likely to see hypotonia that stays essentially the same over time. So the child may be changing as far as their developmental milestones, but the finding of hypotonia is there to stay. This is going to be something to glance at. It's just looking at various causes of hypotonia, and specifically kind of zeroing in on some of the genetic causes. Again, I think these days, having Greenwood Genetics helping us out, they're going to be of assistance as far as what you want to be looking for. So benign congenital hypotonia. I would say the vast majority of kids who have hypotonia, particularly that we're seeing that are a little bit older, are going to fall into this basket of benign congenital hypotonia. Even though it has benign in the title, many times these are kids who have intellectual disabilities or learning disabilities. So it's a type of central hypotonia, but there isn't anything that is evident as far as a specific lesion. So MRI of the brain is normal. All of the metabolic workup is normal, but many times these are kids who struggle in school. They're getting a lot of different therapies. This is a diagnosis of exclusion, though. You're always going to look for a reason. These are kids that over time, when you're reading about it, they'll say, oh, well, the tone recovers entirely. Most of the time they stay hypotonic as far as they're more lax than average, but the hypotonicity decreases as far as severity as they get older. So they're always going to be a bit flexible, but you're not going to see the like this really scary degree of hypotonia as they get older in childhood and into adulthood. You may run into difficulties though with the decreased tone causing them to have some motoric delays in and of itself. So these are often kids that are going to get PT and OT in infancy. They're going to learn to walk though. They're going to go into adulthood and not really have any motoric issues related to it. And so we're going to jump into cerebral palsy now, and I apologize for rushing through, but I couldn't think of any way to cover all of the possible movement disorders without just going really rapidly, and I'm not covering all of them anyway. So cerebral palsy, this is caused by a non-progressive lesion to the brain. It's very important that we're talking about non-progressive. So the picture clinically is going to change for these kids, but the ultimate injury to the brain in and of itself is a one-hit occurrence. The injury is static, and there should be no change in terms of the injury itself on your neuroimaging, like MRI, over time. You know, you may see a progression in the appearance of the scarring, but the scarring should not change as far as location. You shouldn't have a spread in the scarring. It's just going to be there, and then how the child overcomes some of the deficits changes with time. And then also as the child gets older, the picture can change as the child gets heavier. They may have more difficulty with motor skills simply as a function of like their weight and such. So non-progressive injury, the clinical course is dynamic. But it can't be a neurodegenerative disorder. And also, for it to be cerebral palsy, it needs to be in the developing brain. So in the textbooks, they typically say the injury has to occur before 2 to 4 years. Generally, I'd say it needs to be before 2. One of the things that differentiates cerebral palsy from, say, a stroke in an adult is that the injury is to the brain as it develops, as it myelinates over time, and you end up with a different picture than you would see with that same type of injury in the adult mature brain. And the bulk of the myelination process is going to be complete by 2 years of age. So generally, to get your very classic finding, these are going to be either prenatal or perinatal injuries, or very early on in infancy. So the primary findings from cerebral palsy are the most apparent findings are going to be motoric. However, it affects sensory information as well. And more and more with some of the new imaging like DTI, they're learning that a lot of the long-term deficits are actually due to impairments in sensory processing, which ultimately then affects motoric ability. So this is a rapidly expanding field, but it isn't simply a motoric disease, even though the most obvious manifestations are motoric. There are very many things that can cause this. There are genetic causes for cerebral palsy. There are specific injuries like HIE, bleeds that can cause it, metabolic diseases. Sometimes it isn't clear why a child has cerebral palsy. Whenever you're diagnosing it, one of the primary things you're going to want to do is just watch the kid as they go about their day-to-day activities. So, you know, if you're in the room with them, watching them trying to do things, you know, if they're older, you know, how are they helping as far as taking off and putting back on garments? You know, are they reaching for toys? How are they playing? How are they mobilizing? With infants in the NICU, that's a lot of it's going to be watching how they are at rest and how they're moving. So initially with this injury, you're going to be having a primary hypotonic picture. Over time, this is almost always going to progress into a more hypertonic type picture. However, there are certainly subclassifications of cerebral palsy, and we'll get into that in a little bit, where there's primarily a hypotonic picture all throughout life, or there's primarily a chorioathetotic type picture. So you're going to want to watch. You're going to want to feel their muscles and see, you know, are they rigid? If the muscles themselves are rigid, is this velocity related? Is it stiff all the way through a movement that you're performing on the child, or is it something that, like, there's a cogwheel rigidity where it catches? Can you make the rigidity go away if you perform the movement over and over, like kind of work out that stiffness, or does it stay? Is the tone variation a static thing, or does it kind of come and go? Does a child have writhing movements? Do they have dancing type movements? What is the quality of their movement? Are they having difficulty primarily in getting the muscle to move itself, or are they having difficulty with the coordination of the movement? All of this is going to be important, and also looking at what areas of the body are affected are going to be important. So various types of cerebral palsy, and they're going to be classified by this type of movement impairment. So what areas of the body are affected, and what type of movement abnormality are you seeing? And so we've got a breakdown right here kind of showing with spastic cerebral palsy, which is probably definitely the most common cause. It can be broken down to unilateral versus bilateral. And then if you're looking at bilateral, is it the full body bilateral, or is it mainly like the lower legs and the ankles, more of a diplegic type picture? With extrapyramidal cerebral palsy, it's a lot harder to assess, but you'll be looking at quality of movement. These are kids that can be hypotonic throughout their lives. They may have dystonia. They may have ataxia. You may see this choreiform type movement. You may see hemiballismus. All of these kind of bizarre type movements, which can be completely unwanted and can interfere with the quality of their movements and their ability to perform their daily lives. And then particularly with extrapyramidal kids, they are often mixed, so they have qualities of multiple different subheadings. And they may also have some spastic qualities as well, overlying the extrapyramidal qualities. And imaging is really useful with this, because you're going to see separate types or separate areas that are affected with extrapyramidal CP. Many times the areas that are going to be affected are going to be the basal ganglia, and rather than you know, your classic cerebral and white matter injury that you see with, say, diplegia. CP is incredibly common. It was something that I think everybody had, and maybe say 50 years ago, had hoped was going to get better and better as we got better and better in treating babies. However, we've also got better and better at keeping premature babies alive that wouldn't have made it otherwise. So overall, the incidence has actually stayed remarkably stable over time, but there have been some shifts in the prevalence of various types of CP. About 80% of causes are ultimately what's classified as prenatal, in that the issue was there before birth. And this is something that is evident whenever you look at the MRI. You know, this isn't an acute injury. This is something that was there earlier. And so it isn't simply birth injury, which I think as far as laymen go is what they kind of think of. So this can be due to metabolics, it can be due to a structural injury, but most of the time something was going on before, and even if it only became apparent during the birth or in the postnatal period. Risk factors associated with CP, many, take a look. So depending on when the injury occurs during development, you can have a different picture as far as cerebral palsy. And that's because the types of cells that are most susceptible to injury vary as the fetus develops. So during the first trimester, you're going to be mainly looking at migrational abnormalities, heterotopic things. As you progress into mid and late second trimester, you're going to be looking at your classic premature infant, which is probably having difficulties as far as blood flow even before the premature birth. So you're going to be seeing white matter injury, more so than gray matter injury. And if you're seeing gray matter injury, there's going to be a massive amount of white matter injury also related. And then with term birth, like your HIE type picture, you're going to be looking at more gray matter injury compared to white matter injury. Postnatal causes, it can kind of vary depending on what's actually causing it in this postnatal period. This is basically saying the same thing. It does discuss some of the causes related to it. So vast majority of kids who have cerebral palsy have spastic hypertonia. The most common cause is the most mild cause, the most common presentation is the most mild presentation. So spastic diplegia is by far more common than quadriplegia. Kids with spastic diplegia can oftentimes be very functional. You know, I think we have this picture in our heads of what a child with cerebral palsy looks like, and some are very heavily impaired, but many times, you know, we have kids that we see in clinic for something, and you just happen to note, oh, wow, they've got kind of tight ankles. Oh, you've never had an MRI. And so we get the MRI, and there's this white matter scarring, but, you know, they haven't ever been diagnosed. They really didn't have massive motor delays. They're probably not going to be professional athletes, but they're very high functioning people. And so there's probably a lot of people walking around with very mild spastic diplegia that have never received formal diagnosis. With spastic diplegia, whenever you look at the brain on MRI, what you're going to see is comparatively mild periventricular white matter injury. Many times these are kids that were a little bit premature. Sometimes we see this though with kids who are extremely premature and were just really did well. You know, those kids that are micro preemies, but just are very vigorous and just do great, and are the champs of NICU follow-up clinic. Interventricular hemorrhage is what's generally causing this periventricular white matter injury. We grade it based on severity. Many times this can be assessed primarily with head ultrasound, so you don't necessarily need to get an MRI of the brain while the child's in the NICU to kind of track this, unless you're, you know, unless there's a substantial need. Grade 1 just means you've got a little bit of blood there. But that ranges all the way, so a little bit of blood in the germinal matrix, ranging all the way to grade 4, when the bleeding not only goes from the ventricles, but is like progressing throughout the brain, or into outside of the ventricular system itself, into the parenchyma. And dependent on the degree of this injury, you can end up with cystic lesions. You can end up with substantial amounts of scarring. You can end up with hydrocephalus, generally related to the fact that the bleeding in the ventricular system kind of clogs up the cerebrospinal fluid mechanisms for fluid uptake. So you can really have a substantial degree of injury with this, or you can have a relatively mild degree, and a lot of this just depends on the severity of the bleed itself, as well as is there anything else going on that's kind of contributing to the patient's difficulties. Another really high functioning group of people are people with hemiplegic cerebral palsy. This is more likely to happen to term infants than to children that are premature. That being said, a premature infant's bleeds don't necessarily have to be symmetric. So you can certainly have like a grade 3 bleed on one side and grade 1 on the other. But overall, these are more likely to be term kids. It can be due to malformations in the brain. So, we're talking about migrational abnormalities occurring very, very early in development. You can certainly see that this is a cause where, the motor strip was either didn't form properly or was destroyed due to like an ischemic stroke during the perinatal period. Sometimes you can see this because of conditions like Sturge-Weber syndrome, where the ultimate cause of everything is a genetic abnormality that affects the vasculature to half the brain. And children many times don't have motor impairments apparent upon birth, but because of this abnormal vasculature, they'll have a stroke on one side of the brain in early infancy to early childhood. And so you'll develop this spastic hemiplegia type picture. And then extrapyramidal CP. This tends to be the kind of tricky one because it can be caused by all sorts of metabolic, ischemic pictures. Kernicterus we rarely see anymore, but that was one of the primary causes a long time ago. And so generally what you're seeing on imaging with it is not so much cerebral injury, although that can be there, but more of a basal ganglia type injury. And because the pattern is different from what we're normally seeing with the bulk of our CP patients, it can be harder to appreciate. Also, tone tends to be a secondary issue, so there's the quality of the movement as well. As opposed to just one static picture of the severity of the injury, you're going to have to look at the overall quality of their movements over time, which is a more detailed and more difficult exam. As far as patterns of impairment, unlike spastic diplegia, where the legs are affected more than the arms, oftentimes the arms are more affected than the legs in extrapyramidal CP. And many times there's a high degree of speech impairment associated with this. And one thing to really be careful with these kids regarding is their feeding abilities. A lot of feeding, particularly in very early infancy, is reflex-based. And as kids progress through the first months of life, this is going to go away and be more heavily dependent upon actual motor coordination. And so there are kids that feed really well in early infancy that just really stop being able to feed, aspirate, and ultimately may need feeding tubes that, right at infancy look great because we were assessing their reflexes, not their motor pathways. And so probably the hardest one to identify, and the one that I think scares us the most, is hypotonic cerebral palsy, because many times this is due to mitochondrial disorders. So these are kids that probably ultimately have a degenerative condition. And certainly are more likely to impair over time, to have a progressive injury over time. And so probably don't fully qualify as being cerebral palsy because this is a progressive injury. As we said before, many kids are a mixed picture. So a child that has a spastic quadriplegia very often may have extrapyramidal elements on top of that. A child who has a primarily hemiplegia may have some impairments on the other side as well. Sometimes we run into kids that have a multitude of different etiologies kind of lining up. And so this is particularly true, I think, of the extrapyramidal kids where you're more likely than not to be in multiple different categories. So you have chorioathetotic movements, you have dystonia, you have ataxia, you have a lot of different things going on. And how child presents can change over time. We were talking about this just a little bit at the very beginning, but at early infancy, if the child has cerebral palsy due to, say, HIE, they're going to present as being limp, hypotonic, like we talked about in the prior lecture. Over time, they're going to become hypertonic. The injury in and of itself hasn't changed, but the presentation has. Kids that have a really severe spastic diplegia may be fully mobile at 4 years of age, but as they get older and they get heavier, they may end up being wheelchair bound, not because the injury itself has progressed, but because they've gotten heavier. Maybe they haven't gotten as intense therapies, they have worsening contractures, things of that nature. So even though we're talking about a static injury, the outside manifestations can change, and unless the child gets appropriate therapies, their appearance and their functioning is going to worsen, even though the underlying injury to the brain itself isn't going to worsen. Many kids have comorbidities. The comorbidities tend to depend, not surprisingly, on the underlying cause of the cerebral palsy. And so, like with spastic quadriplegia, you're more likely to have intellectual impairments than with spastic diplegia, which makes perfect sense because you're talking about severity of white matter injury. Kids with hemiplegia, because it's more likely due to either migrational abnormalities or to a stroke, they're more likely to have epilepsy. It's important to know comorbidities that are more likely to be associated with any given finding, so you know kind of what to screen kids for. And as far as counseling parents, well, what to tell them to really look for. So evaluating for cerebral palsy, history, family history as well can be really important, developmental history. What are they having difficulty with? What have they had difficulty with in the past? On exam, watching movement and not simply just assessing passive movements as we move their muscles through range of motion and all of that, but how are they doing as far as reaching for objects? How are they doing as far as putting on their clothes, riding, that sort of thing. As far as workup, I'm not going to stress this too much because I think most of the time these kids receive a pretty thorough and appropriate workup. I think where we tend to fall by the way is in assessing for comorbidities, because their quality of life is a huge issue with cerebral palsy, and many times it's a comorbidity that's having a dramatic effect on the quality of life overall. Another thing to take into account is that things that can affect quality of life for the family may seem small to us. So many times we don't really think about orthopedic procedures in children that aren't mobile, but an orthopedic procedure that allows the family to clean the child better can have a significant impact over their quality of life. You know, this can really improve how the family is able to function, how they're able to provide care for the child. And it's something that we may not necessarily think about just seeing the children in clinic. As with everything, there's a spectrum of severity. Generally, whenever we diagnose someone with, the quotes cerebral palsy, the child has motor impairments greater than 50%. There are certainly kids that are impacted to a mild degree that don't end up with a diagnosis of cerebral palsy, but that have mild brain lesions contributing to it that simply are not severe enough to give you the full picture for a diagnosis. These are kids that may often benefit from PT and OT as well. They're almost certainly going to benefit from having some supports in the classroom. These are kids that often have severe graphomotor disorder, so having handwriting supports, keyboarding supports, that sort of thing can dramatically help them, even though they're not going to qualify for cerebral palsy diagnosis. That doesn't mean they don't necessitate a little bit of supports. And I don't know how much time. We basically have no time to cover Duchenne muscular dystrophy. What I will just scan through very quickly, Duchenne is the most common cause of like a progressive weakness in kids. It's X-linked. So of course it's going to be affecting males. That being said, about 20% of carrier females can have some weakness. And so it's important for them to be screened because particularly weakness affecting the heart can kill them. So when you're assessing a family, don't just assess the boys in the family. This can be something really insidious. So sometimes we see kids referred to clinic where they've just gradually gotten weaker and weaker over time. And by the time we see them, they're crawling up the stairs. But there's a gradual onset and things just because they can get so, it's so gradual, the worsening. Sometimes it can really take a while for the family and the physician to kind of pick up on it. The things that you're going to see first, though, are going to be more easily fatiguing. They're going to be some subtle abnormalities in gait. And then you're going to see, oh, wow, this kid is having immense trouble getting up like off the floor. I have some signs here of the Trendelenburg gait and Gower sign. And essentially Gower sign is just the kids on the floor, you ask them to stand up. They can't get up without actually using their hands to kind of walk up their trunk to straighten up. And that is a classic sign of proximal weakness. And Duchenne muscular dystrophy and the other muscular dystrophies are primarily proximal muscle weakness. As far as workup, the pediatricians often will order a CPK, and that's like the major thing to order. So one thing to be aware of, AST and ALT can be elevated simply because of the degree of muscle breakdown. So occasionally we've had kids that we've seen before they actually started to have motor delays, and their AST and ALT will be elevated before that. So we've had kids referred for like learning disabilities and stuff like that, and we're assessing them prior to starting stimulants, and the AST and ALT will be elevated, and we recheck it and it's elevated again. And then you send the creatine kinase and it's sky high, and you've diagnosed a kid before they have any motor signs. With Duchenne muscular dystrophy, your creatine phosphokinase levels are going to be in the tens of thousands. So there's nothing at all subtle about this result. Repeat it because there can always be lab errors. But if you're dealing with tens of thousands, as far as values for creatine phosphokinase, one of two things is going on. You either have Duchenne muscular dystrophy or you have rhabdomyolysis. So unless the kid has had a crush injury or something like that, typically they're very different presentations. In a child with progressive weakness, if the CPK is sky high, you've got Duchenne's. So your next step is going to be referral to neurology, but what we're going to do is send them to genetics for sequencing of the gene. The dystrophin gene is huge, and we think that's the primary reason why lethal mutations in it are so common, because typically these kids, typically whenever you have a lethal mutation, it's relatively rare. But it's such a huge gene that just by chance, you're more likely to have mutations in it than a lot of the other genes. But sequencing of it is essentially the only way to figure out severity other than sitting around and waiting on the progression. Treatment is primarily prednisone and then supportive therapy. And one thing that I will just leave you guys with to look at later is exon skipping therapy. Exon skipping therapy is a new type of gene treatment. Essentially, what they're trying to do is switch someone from a Duchenne to a Becker type phenotype. So they use a technology whereby by cutting out a mutation, you end up with a higher level of functional protein, even though you're snipping out part of the protein. And it's a little bit counterintuitive until you really map it out. I'll talk with you guys later in detail if you want to, but it initially showed a huge amount of promise, and the thought was, well, you could essentially transition someone from Duchenne to Becker muscular dystrophy. Two things happened. The early data has shown that the delay in becoming wheelchair bound is only about 2 years. And then the other thing is that the drug companies priced it so high that they essentially priced themselves out of the market. So we have had very limited luck getting insurance approval for these medications, even though they do extend the lives of these patients. There are some similar, not identical, but similar technologies that have been used with SMA that have had more substantial improvements in outcome. And so we've had much more luck getting them covered. Another key is probably that SMA is much rarer than Duchenne's. Exon skipping therapy, I have hope that there will be improvements in the overall therapies and in the functional outcome with treatment, but also that over time we'll be able to drive down the cost of these medications, because they really do improve quality of life. So I'm sorry to really have rushed through. Just look through all of this. If you have any questions, let me know, and I'm happy to give further details at any time on any of these topics. But that is a 1-hour overview of movement disorders and muscle disease. So I'll see you guys later. Let me know if you have any questions, email me, whatever.
Thank you, Dr. Gregory.
All right, thank you.